this out to you is to let you know that, in fact, with good diagnostics, good equipment, and with a good hygienist, most periodontal disease can be treated successfully without any surgical or any other intervention whatsoever. And given the recent developments that have occurred with regard to the use of EDTA to chelate the minerals, particularly chelate the calculus, from the root surface, I think, given our 25 years of success and now using EDTA for over a year, we've got a handle on all of this perio. Now, there are some people who are going to insist that they want to use other adjuncts. That's fine. The principle of what we're going to talk about today is the root and the body can heal. The body can heal if the root is clean, and we now have the technology, both through endoscopy and now through EDTA, to get the root completely clean. So let's begin with the case. So this patient came into our office. This patient actually had seen the general dentist. The general dentist had said, you need this tooth out, and then you need to go see a periodontist. The patient said, nothing doing. I want to see the periodontist first. And she called us, and she was in pain. We saw her about, I think, the day after she called. And she was scared, and she was in pain, and this tooth number 24 was loose. If you take a look at the radiographs, you can see the amount of bone loss that's present on this tooth, but you'll see that other teeth have bone loss as well. I'm not going to go into that in detail. I want to go over the endoscopic part of this, but I just want to show you what can be done in a periodontal office. This is the CT scan. And now you see a close-up of this tooth, which is severely periodontally involved. You can see how swollen the gum tissue is. And I could wiggle this tooth in my finger if she would let me. And it was the only tooth that she was touching. You can take a look on this side. You see lack of bone support. Maybe it's being held on a little bit at the end, but the tooth is so loose that I didn't blame the general dentist for wanting to take it out. It made perfect sense to me. And if we take a look then at other portions, other teeth, we're seeing bone loss. You'll see bone loss between the two roots of this upper right second bicuspid. And if we look at pocket depth, you can see how severe the pocket depths are with 8 and 9 on the distal of tooth number 4. But if we look at all of the pocket depths all throughout, you can see how bad this is. And this is, by definition, an aggressive periodontitis, not a lot of calculus, and that's why I'm not going to dwell on this, but I do want to show you that the body is capable of healing if we give it a chance, and we will show that in some detail. So there's a great deal of mobility on this tooth. I didn't even probe this tooth. It would have hurt too much. She was scared anyway, and it hurt. But it shows the influence of occlusion. She was banging on this tooth. So not only did I have a lot of bone loss, but the tooth had erupted and she was banging on this tooth. It was the only tooth she was touching. She didn't want the tooth out. So what's the next step? And the next step is to do a bite adjustment and just remove the occlusion from that tooth. And she felt immediate relief. I mean, it was just night and day. At that point, I saw what appeared to be an aggressive periodontitis. I prescribed the typical things you prescribe. Here's what we would do in a long-term case. For many of our cases where we suspect aggressive bacteria, we'll ask the patient to spit in a cup and send it out to, we use oral DNA lab, and find out what bugs are growing. And she had high levels of high-risk pathogens that were present. We couldn't wait, so I just prescribed what we would ordinarily prescribe in a case like this. I prescribed amoxicillin and metronidazole. And the impact of antibiotics is important. This comes from a recent review in diagnostics, which shows that antibiotics and the reversal of the periodontal pathogens lasts far longer than what we even thought. And reversal of pathogens at least can last up to a year and perhaps longer than that. And so it does emphasize that in the correct cases that antibiotics can and should be used in conjunction with periodontal treatment, and that would have to do with the aggressive type of organisms. Well, we take a look at this patient, and I didn't have a picture when she came back. We had not even splinted this tooth, but just the antibiotic created a great deal of resolution in this area here. We splinted the tooth at that point. I couldn't splint it the first visit. It was an emergency visit, but we got some time to splint it next visit, and she was perfectly fine with that. So there's the before with periodontal pocket depths, and here's the after. After we did periodontal endoscopy and after we used antibiotics. And this patient is thrilled. She still has that tooth. If you take a look at pocket depth here, the one we showed initially, and how the pocket depth has changed, just tremendous results. And the patient is capable of healing. You notice more bone support on this tooth number 24 than we had to start, and we verify that on the CT scan. So here's the CT scan at the initial evaluation. Here's the CT scan a year later, and we're seeing more bone regeneration around the tooth. So that's the concept that the body can heal, and that's why we don't want to give up on periodontally involved teeth. But let's go to traditional periodontitis, which is greater than 90% of the people that we see. They have calculus on the root surfaces. And Sokransky, as well as most of the originators and one of the forefathers of periodontics say the same thing, and that is the establishment and maintenance of a clean, biologically acceptable root surface is fundamental to the successful treatment of periodontal disease. What I'm going to point out to you today is that we have not been able to achieve that, and we are achieving that now, and we're doing it with periodontal endoscopy, and we'll show you some examples of that. So in 1984, Roger Stambaugh did a study. He essentially told hygienists to spend as much time as they wanted scaling a tooth or scaling teeth. And these were teeth that were going to come out anyway because they're going to come out for a denture. So the hygienists spent as much time as they want. They spent something like between 25 and 35 minutes per tooth getting the tooth clean. Then they extracted the teeth. They looked at the teeth under the microscope. And the average depth for removal of plaque, calculus, and altered cementum was 3.73 millimeters. And in no case were they able to remove or get the root clean below 4 millimeters. Well, most pockets are deeper than 4 millimeters. Here, Amanda is doing a scaling, and I'm pointing out the calculus on the root surface, and we're using a periodontal endoscope in this area so that the hygienist can see that. Here's Rebecca, who started our endoscopy program in the year 2000, talking about her initial experiences.
It was amazing what you could see. It took time. You couldn't just do it one time and say, I give up, because you had to keep at it. I had to go to Dr. Sheldon and say, I need more time for some patients because I can't get it. I know it's there, I see it. So you get, stop. Or it's been a pleasure to use that. Our first one we had, it was like black and white, but it was great, it was. Then we got the next generation, which was like a color TV, 4D, it's just like, wow. But it still takes time, and you can't give up on it. And some patients are easier to work on than others. Sometimes it's faster, sometimes it's slower, but it's just made the healing so much better. So the areas that we still have bleeding in, maybe still have some calculus, or they need some surgical intervention.
This is Rebecca, who introduced our periodontal endoscopy program, and it was very simple. I'm a surgically oriented periodontist. I cut. I've spoken to the American Academy of Periodontology on placement of subperiosteal implants. I did that in the 90s. I've talked on practice management, and that's how I'm known in the field of periodontics, and that's practice management because I teach periodontists how to run a practice, and frankly, I teach them how to run an independent practice. So there are lots of things that I've lectured on, but this is one of the fundamentals of our practice. In a very large practice, what we saw was that, well, let's go back to the typical thing we would be to do scaling and root planing, and then we wait 6 weeks and we reevaluate, and then I would determine at the time of the reevaluation what areas were inflamed, what areas were bleeding, and therefore what areas would need surgical intervention, which is what Rebecca just said. Rebecca was the one who started this program. She started this program in the year 2000. So that's where 25 years is coming. I'm recording this in December 2025. And as Rebecca got used to this, and Rebecca would come, literally she'd come crying in my office, because as she said, I need more time. I can see it. I can't get it out. I'm frustrated. What do you want to do? I didn't give you that part of the recording. And essentially I said, take all the time you need. Learn how to use this. And this was a crude scope, not like the scope that is being developed today. But what I found was that I would reevaluate Rebecca after using the scope, and I'd say, you don't need surgery. And then that went on and on again. You don't need surgery. You don't need surgery. You don't need surgery. Rebecca was getting all the periodontal disease under control in a periodontal office where people assume that I'm going to do dental implants. So that's what was happening. And Rebecca retired a few years ago, but her record of success is now duplicated by other hygienists that she trained and are now training others in order to be able to successfully use a much better endoscope so they can visualize what's on the root surfaces. Here's the video showing the use of the periodontal endoscope.
Got it.
Wow.
Keep going.
Yeah.
Keep going.
Okay.
Get all that stain off, yeah. Keep getting it. Yeah.
Wow. Okay. Okay, this was a medium. Go ahead and go right there. Beautiful.
So that's a 7mm pocket, and you can see the indentation in the root itself. There's no way that anybody could get that by feel. But what Jessica's doing, was training to do this. At that point, she was able to get in. And she was able to see it with the scope. At the same time she's seeing it with the scope, she's treating it with ultrasonic instrumentation in order to be able to get that out. And I'm not saying ultrasonic instrumentation is the only thing that should be used. But we begin with ultrasonic instrumentation. We'll follow it up with hand instrumentation, always. But now with EDTA, that is actually making our instrumentation go even easier and faster because the EDTA is taking off that last layer, that last layer of micro islands of calculus I'm about to talk about. There was a study done in Journal of Periodontology published a few years ago that looked at patients who had been treated, and they'd been treated 10 years previous, and the periodontist got them back 10 years later. They hadn't had continuous treatment or anything, just to see how good treatment worked and how successful good treatment was. Now, this is not endoscopic treatment. This is any treatment that the patient needed. And they were looked at particularly periodontally compromised teeth, where many people would say these teeth are hopeless, but in fact, the teeth are not hopeless. Let's take a look at that. So they saw 97 patients, over 2,000 teeth, and they were looking at them 10 years after periodontal treatment. The overall tooth loss was 119 teeth. That was 5.1%. So these are advanced cases, and still the overall tooth loss was only 5%. And the tooth loss due to periodontitis, only 1.7%. The other teeth were extracted for other reasons, prosthetic reasons, or they had tooth decay. So it begs the question, how hopeless are hopeless teeth? So if we looked at all the teeth with initial bone loss, just take those. Initial bone loss of greater than 80%, 14.3% of those were lost. But only 2 of them were lost for periodontal reasons. We're making too many decisions to extract teeth too early. And if we can get the root surface clean, these researchers were not using endoscopy, but in my practice, with endoscopy, without surgical intervention, with a less expensive treatment done with a hygienist, we can duplicate or even do better than these results. And I'm going to show you some data to reflect that a little bit later on. So in terms of overall tooth loss, there are some teeth patients who would just have poor protoplasm. They're going to lose more teeth. And we see that in dentistry all the time. There's some people that just don't heal. But this data is obviously very sobering and encouraging. Dr. Charles Cobb and Dr. John Sottosanti did a reevaluation of scaling and root planing, which I thought is important, particularly when we're talking about periodontal endoscopy. And what they found is the periodontal inflammation is clearly related to the presence of calculus and biofilm. But notice it's calculus and biofilm. There's a lot of discussion now about biofilm only, and I'm going to show you why that discussion may be incomplete. And scaling and root planing requires time, exceptional skill, and perseverance. And I'm also going to say it requires a scope, because that allows for the exceptional skill to be used and used appropriately, as you saw Jessica doing under Morgan's tutelage. So let's take a look at a root surface. And this comes from the Cobb and Sottosanti article. And we're going to look at the area of the calculus only, and I'm going to show it to you from a number of different perspectives. So this is the surface of the calculus, and the calculus is not smooth. The calculus has labyrinths. It has spaces within it. It's like Swiss cheese. And within those spaces, then you're going to find bacteria within those spaces. And that's why there's the biofilm removers certainly aren't enough, because there's no biofilm remover that's going to get into this microscopic cavity and get rid of this bacteria. We need to remove this microscopic cavity, which is essentially calculus. That's harboring the bacteria. Let's look at it from a different perspective, and you'll see that I've colored the calculus on the right side. I've colored that brown. And one thing that you will see is that there's a microprojection, and this is found routinely in calculus all the time. That the calculus just doesn't rest on the surface of the root. The calculus itself is embedded within the root. So when a hygienist goes in, and the hygienist will do her ultrasonic cleaning, the hygienist is looking for this calculus flying out. And boy, that makes the hygienist really happy. But actually, here's what's going on. If we look at this same model, there's the ultrasonic scaler, and what will happen is the calculus will break off. It always breaks off from itself. It does not cleave off of the root surface. And so in Cobb and Sottosanti's article, they describe this as fractured calculus. And fractured calculus is always there. And that is that's the reason why we have to do better in our calculus removal. So what a hygienist will do by feel, and we all know the hygienist can only get in 4 millimeters, if that far, and the hygienist will scale and root plane. But when the scaling and root planing is done, there's still this calculus left. The only way we can see the calculus, and that's what we see routinely after scaling and root planing is done in other offices, is to place a scope down there. And now we place the scope down there, and now you can visualize the calculus. And that's what's important for this first part. So now the hygienist, while visualizing the calculus, just as you saw Jessica do, but this is with a hand instrument, is to remove that calculus. And now that calculus is gone. Or is it? Notice we have these microislands of calculus. And these microislands of calculus remain. I'm going to show you more in this Steve Harrell and Charlie Cobb's article, where they looked at microislands of calculus. And what they did very simply was to take extracted teeth. They embedded them in plaster, and they removed the outer ring. You can see the outer ring where they actually drilled around the calculus, so they had smooth tooth structure so they could identify where the calculus was. So what you're seeing in the center of this ring, this is the calculus embedded portion of the tooth. And there it is in close-up. And what you'll see where they're pointing, you'll see these white areas. And these areas are areas of microislands of calculus. So let me go back for a second. What they did was scale and root plane. Using every traditional periodontal instrument they can, they worked on it, worked on it until they got the root as clean as they possibly could, looked at it under light microscopy, and you're seeing what you're seeing. And these are the microislands of calculus. So then they applied EDTA. EDTA has been used in medicine for a long time. It's like a chelating agent. It essentially removes a metal bond from the calculus itself, and so the calculus is then removed. It's non-acidic. It's non-toxic. It's been used IV for chelation therapy for years and years and years. And so notice this is the way it looked on the left side, and then after they applied the EDTA. And they did the experiment. They applied it for 30 seconds, for 1 minute, and for 2 minutes to see what the optimal amount of time was for use of EDTA. And what they did was to burnish it in or rub it in. They found that 1 minute was the optimal. 1 minute did as well as 2 minutes, and 1 minute did better than 30 seconds. And so 1 minute is the rule after scaling and root planing is done to remove the microislands of calculus. They found that scaling and root planing alone removed greater than 60% of the calculus. That's good. They were doing it under direct vision. But then burnished 24% EDTA in, and now that removed most of the rest of the calculus. And the calculus did remain, had different morphological characteristics entirely. So when you have microislands of calculus, this is what happens. You end up with a root surface that's highly inflamed. An inner epithelial lining or an inner gingival tissue that's highly inflamed. And so you probe that and it's going to bleed. And that's the key in our article talking about decision points in periodontal therapy, that if it's bleeding, it's not under control. You've got to go to advanced therapy. Well, here's the microislands of calculus, and at least this is my rendition of what is happening with microislands of calculus. So now you remove the microislands of calculus, and now as a result, the tissue can heal. And that's the only way the tissue will heal. The microislands are toxic, and they also harbor bacteria. So this is the way we do it. We apply 24% EDTA gel after we've taking care of everything that we can, and then just burnish that up and down with a micro brush, and now the calculus is clean. Now, calculus is a risk factor for periodontal disease, and I just talked about that, but I didn't give you the fundamentals here. Calculus, we think, works in at least two ways. One is in a way in which it harbors bacteria. But the other, which we don't talk about as much, but there's plenty of literature to state that. By the way, here's a piece of calculus, and this is what happens when we don't remove the calculus. You'll find inflamed gum tissue around that. And Steve Errol noted that through the use of the videoscope, and this was an open procedure, and of course I'm talking about using it as a closed procedure, and that's where we are with endoscopy, and that's what we've been doing for 25 years. We did not use the videoscope as Steve did. We used a periodontal endoscope. The brand name at that time was Perioscope, and we were able to get the results that we have. But this demonstrates the calculus that we see, whether open or closed. There are lots of, I've only taken some of the literature that talks about the fact that calculus itself is a nidus for inflammation, and that in fact there is an immune response to the toxic calculus itself. Even sterile calculus has been shown in some in vitro studies, both in animals and in humans, showing that calculus itself is toxic, and that's the second reason, besides harboring bacteria, that it should be removed. So this is where we start off, and this is my own conception, or this is what I asked ChatGPT to do. So there's regular islands of calculus, and then we remove that, and that's what we've been doing what we think is quite well for 25 years, but it still leaves micro islands of calculus as demonstrated by Harrell and Cobb. And our goal is to get the root completely clean. That's what we need to do in order to be able to get healing. And it's interesting that we've been able to get some healing, quite a bit of healing, in our 25 years. We've lost very, very few teeth due to periodontitis without using EDTA at all. So imagine how well we can do with a trained hygienist who's given the time, who has the scope to use and can see below 4 millimeters in order to be able to get that root surface completely clean. And now we add EDTA to it, and now we have a pristine root. So I'm proposing that there's a reset button that we need to we need to set. That in fact, all of the treatment that we've been doing up until this time has been in the presence of toxic calculus, and still we've gotten some results. But have we studied enough patients where the root is completely clean to see how much healing we can achieve? And the answer is no. We can only say in Lee Sheldon's practice, and there are other practices, there's some endoscopy practices throughout the country who've gotten the same results that we have. But endoscopy has not caught on yet, and it's about to. And it is because we have this data and because we have a number of people who are going around the country saying, hey, we've got to stop over-treating periodontitis. That if there are over 200,000 hygienists in the United States, and most hygienists want to do the best job that they possibly can. And if we give them the tools and the training to do so, we can heal a lot of patients. Don't forget, 42% of the people over the age of 30 have periodontitis. It's the 6th most prevalent disease in the United States. And if we can give the hygienist the tools to be able to solve these problems, then in fact, they don't have to see people like me. They can see the hygienist, they see the frontline therapist, and as long as the dentist gives them the time and gives them the tools and gives them the training, we can get a lot of the periodontitis under control and reduce the cost to the patient. That's the big point. So that's the number one thing in my opinion. Let's get the root surface clean. We know how to do it, and we have a track record to show it. In 1996, Charlie Cobb again, Charlie's a fabulous researcher and knows the literature backward and forward. And he was asked by the AAP to come up with, to do a literature review on non-surgical periodontal therapy, what was in the literature. And it was well over 20 controlled studies, I mean, in centers. And what they found was, at that time, and I don't think scaling and root planing has really changed much. So in 1996, I agree, is a long time ago. But scaling and root planing is scaling and root planing. They found an overall improvement of 1.29 millimeters, and in the deeper pockets, meaning greater than 6 millimeters, an improvement of 2.16 millimeters. So we did a case series. We just took 13 consecutive patients and looked at them ourselves in our own office to see how we were doing. We were curious too. And what we found was in the deeper pockets, we got the pocket depth was improved by another millimeter, more than another millimeter. And the overall improvement was almost twice as good in our clinical study as what's in the literature. That's not proof of concept, but it's certainly indicative of concept that in fact, hygienists, given enough time, and I'm repeating myself, can accomplish these results. There are a lot of people that are being condemned, or their teeth are being condemned. And so here's an example of what occurs. And you can see this calculus on the root surface here, periodontal endoscopy, and the bone will come back. If we take a look at anterior teeth, 15 months later, you see the difference between the radiograph on the left and the radiograph on the right, more bone support. Same thing, here's a long-term case, a 5-year case, and you can see more bone support, or at least as much bone support. We can certainly argue about the angulation of the x-rays, but these patients are healing. They heal well, and they heal well without the need for me to intervene, other than do the diagnostics and to prescribe antibiotics at the appropriate time. There were a couple tools that we ordered in order to be able to make that happen. So the first thing is we're using Pref Gel. Pref Gel's been around for 25 years.
3 different sizes of micro brushes. What I've noticed is that the extra fine purple tips seem to work the best and get into percations and just really tight pockets with very fibrous tissue. And so, you just kind of squirt a little bit into the pocket, and then I'll go in with my micro brush and just kind of graze the surface for about 30 seconds to a minute. And you can feel it getting smoother and smoother. And then you just go in and rinse, and then I'll go in with my scope, and then you can kind of see little
Like ridges
from me kind of moving it and going over the surface multiple times, and then it just comes off like that.
Yeah.
It's also a deterrent for stopping the blood. It just makes me able to see and view things.
What have your post-ops been like on the root planing cases or on the periodoscopy cases?
Just phenomenal. The tissue is tight, no bleeding, 1 to 2 millimeters. Just this one guy had great, especially around furcations, class 2, 3 furcations, super tight tissue around it. Yeah.
So Morgan, what's the protocol we're using now?
So the protocol we're doing is we're going to apply the Pref gel at the beginning of the appointment in any pockets 4 millimeters or greater. We're also going to then Cavitron, everything we can feel, Supra. We're going to go in with the scope, remove the calculus as we normally would do, and then we're going to Pref gel throughout here and there, and then hand scale, use some files, and then we'll Pref gel right at the end. Make sure to rinse in the pocket, and then go and rinse, and you'll see a clear as day, smooth surface. I think it's a real game changer in the hygiene field.
So as we look at this, understand that Morgan was hygienist and she worked in corporate for a number of years, and then she came to work with us. And it was a matter of her just training to be able to do this, and she was able to duplicate the results that Rebecca did. What she was talking about with the EDTA, she actually found, her statement was, if I can use EDTA at the end to remove the microislands of calculus, why don't I use EDTA at the beginning and see what happens there? And what she found out was that it softened the calculus and made her scaling and root planing, her initial scaling and root planing, that much more effective. So essentially what she does is apply the Pref gel first, then rinse that off as stated, then goes in with the scope, and that was where she was talking about seeing the ridges in the heavy calculus, so she can see that and get that calculus off even more readily under the scope. She's looking directly at that. Once she's done everything she possibly can with traditional root planing instruments, ultrasonic instruments, and hand instruments, then her final step is to go back with the micro brushes and EDTA to be able to remove the microislands of calculus, and then she's done. I hope this gives you some perspective on what we're doing and what we've been doing for the past 25 years. I think endoscopy is very, very important. It essentially got me out of doing periodontal treatment. It forced me into becoming, I was known as a dental implant expert in my area, simply because I needed something to do. The hygienists were getting everything under control. And the need for me to do periodontal reconstruction, other than for other things that we would do periodontal treatment for restorative purposes, or to build up soft tissue, or to do bone grafts in conjunction with dental implants or something like that. That was kept to a minimum. It doesn't mean that I never did periodontal surgery, but only a few times a year. That was it. So I want the endoscopy to get better and better and better. We have over 200,000 dentists and over 200,000 hygienists who can take advantage of this. The hygienists want to do a better job. And once they see this, when I lecture, they want this technology. If you have any questions, just give me a call. I don't have my phone number there, but my phone number is 321-258-7467. If you want to see more of my materials, then just go to that says youtube.com. Go to leesheldonlectures.com. Yeah, leesheldonlectures.com. And you'll see a lot of my materials there, as well as a patient education video. I thank you for taking the time to look at this, and I certainly welcome any questions you might have.